That down.
Manage 5050 B12. Oh, yeah. Same.
It's right. 50 55 845 1662.
Once again, a very warm morning to one and all present here. I, Symposium,
And I, Yash Kumar,
we welcome you all to this session on acute myocardial infarction and cardioprotection.
this session shall be presided over by our chairs, Professor Malcolm Walker and Professor Derek Hosenloy. Professor Walker is qualified in medicine from the University of Birmingham with cardiology training in London and Oxford. In the course of his meritorious career as a clinician, he founded the Hatta Cardiovascular Institute, following which he established a dedicated cardiology clinic for patients with disorders of hemoglobin, where, in collaboration with Professor Dudley Pennell, the MRI T2 for non-invasive tissue iron measurement was developed, the clinical use of which has been credited with a more than 70% reduction in mortality in thalassemia. With over 120 articles published under his name, his recent endeavors have led to the establishment of cardio-oncology at UCLH, with the first clinic undertaken in 2016. This service has expanded to see over 800 patients.
Professor Derek Hosenloy is an eminent researcher and academician. He is a professor in cardiovascular and metabolic disorders program at Duke-NUS University of Singapore, and is also a professor in Institute of Cardiovascular Sciences at University College London, United Kingdom. Currently, Professor Hosenloy is the director of National Heart Research Institute in Singapore with 338 peer-reviewed articles since year 2002. He has been guide to 11 PhD scholars and 16 MD students. Along with this, he has earned a significant research grant in Singapore over the years.
Professors, we welcome you to this session. Before proceeding, I would like to advise all the speakers to each conclude their speeches within 20 minutes, following which a 10-minute question and answer session shall be held. Thank you.
So, without any further delay, I would like to introduce you to our first speaker for this session, Professor Sean Davidson. Professor Professor Sean obtained his PhD in Melbourne, Australia. Then he moved to Paris for his postdoctoral position and conducted a research on the development of heart. In the year 1998, he moved to London and is currently professor of cardiovascular research at the Hatta Cardiovascular Institute at University College London, where he investigated cardioprotective measures with focus being exosomes. He is actively involved in the scientific community as secretary of the International Society for Heart Research European Section. He is an associate editor of cardiovascular research and cardiovascular drugs and therapy, and is also on the editorial board of Basic Research in Cardiology. I invite Professor Davidson to please come on the stage and give us a talk about his paper titled The Role of Extracellular Histones in Ischemia Reperfusion Injury.
Well, thank you very much for that very kind introduction, and it's a pleasure and a real privilege to be here to talk to you today. I work at the Hatta Cardiovascular Institute in University College London, and I collaborate a lot. It's in the same department led by Professor Derek Yellen. So a lot of my work will carry on from what we just heard before, where you saw we are very interested in the risk pathway and ways to try and protect the heart from ischemia and reperfusion injury using the risk pathway. But we think that this is really ultimately just one of the ways of protecting the heart. And ultimately, as you saw, it can be challenging in a human population where there are many comorbidities. So it's likely that we will need other approaches to protect the heart. So I'd like to talk to you a little bit about another angle that we've been looking at, and this is related to the role of extracellular histones. So just as background, I'll remind you about the structure of the cell. Of course, we have many genes encoded in our DNA, around 20 to 30 or 20 to 25,000 different protein coding genes. These are all amongst our chromosomes, which if you took out the DNA and stretched them out, that it would reach nearly 2 meters. But amazingly, this is all condensed down into a really small structure in the nucleus. And to do this, to enable this, the cell needs to wind the DNA up with these nucleosomes. And as you can see, so this is a basic structure of the nucleosome made up of multiple different histone units, which form this octamer, which then binds to the DNA and winds it up tightly. That's just some more detail there, showing how the DNA winds around these histones. And histones are also interesting because they're used in inflammation. This is a neutrophil in yellow, and you can see when there's inflammation occurring, these neutrophils can jettison large quantities of their DNA and containing histones and nucleosomes, and it's used as a defensive mechanism to trap bacteria and destroy them. So histones can be destructive as well as part of this net structure. So histones have been categorized as a type of DAMP, or damage-associated molecular pattern molecule. And this schematic is illustrating how these can signal inside cells. DAMPs they act a little bit like pieces of bacteria and can stimulate this pathway, activating an inflammatory response inside the cells. So we were interested in whether histones might be released when we have an infarct in the heart. The cells are releasing lots of their contents. Histones are released also from the DNA, and could potentially contribute to this infarct, as you saw in these images similar to the ones in the previous talk. So to do this, we used a similar, basically the ischemia reperfusion model, which we heard about just before, where we have this beating heart. This is an isolated rat heart subject to ischemia reperfusion. So 40 minutes of ischemia, reperfusion for 2 hours. And then we measure the extent of injury, and we also look at how many nucleosomes are actually released from the damaged heart. And this is a graph showing over time. During the early reperfusion, 15 minutes of the reperfusion phase, we can see a sharp increase in the amount of nucleosomes released out from the nucleus. And of interest, we saw this histone H4, which I'll come back to the importance of that later, but that's one of the histones being released from the damaged cells. And there was a correlation in the end between, if we look at the size of the infarct and the extent of histone release. As you might expect, the more damage, the more histones come out. Now, histones, I mentioned these can potentially be toxic. So what we did was we put them on cells which have been isolated out of a heart. We isolated the cardiac myocytes from a rat heart. We can put them in a dish. We can take some purified histones, put them on directly. And we saw these were actually very toxic. Within 1 hour, at this different doses we tested here, there's a huge dose response damage to the cells dying caused by the histones. And you can see that looking down a microscope, the cells are just destroyed. These are 2 different assays on there. But also in the isolated heart model, this isolated Langendorf perfused heart, if we perfuse these hearts with the purified histones, we can see at the 20 micrograms per mil dose, there's a large increase in the infarct size after a ischemia reperfusion injury if we add additional histones. And then we also saw, looking at the cardiac function, the heart function is similarly decreased. And in the flow rate, the flow of the buffer through the heart, this is also reduced when we have these with histones. So histones are damaging to cells and hearts. We wanted to then see if we can remove the histones, mop them up, and protect the heart. And to do this, we used this compound, which was developed by collaborators in Australia, who obtained or developed this molecule based on this molecule. And we can see this is a highly charged molecule. This is called MCBS. His DNA is negatively charged. Histones are actually positively charged. So this synthetic compound, highly negatively charged, can act to bind to histones and hopefully remove them and detoxify them. And this is what we saw first on cells. We treated isolated myocytes with the MCBS. First of all, I'll show you the increasing color or darkness is the increasing quantity of MCBS. So on the left, we're just treating them with the histones and causing toxicity. In the presence of increasing amounts of CBS, and this is the best one on the right, we can see we're almost completely eliminating the toxicity from the histones by extracting them or removing them. On the right-hand side, we can see that more simply using a different assay. This is just the amount of dead cells measured. Histones are causing toxicity. Again, the MCBS, especially at the higher concentration, is preventing that toxicity. What about in the isolated heart? So we saw it protected the cells within Langendorf perfused heart. This is looking again at the infarct size after 45 minutes of ischemia, 2 hours reperfusion. That's our standard research model. And we could see 60% infarct in the control hearts. This is the ischemic preconditioning, which we heard about in the previous talk. So we use this as a positive control to show our experiments are working. Ischemic preconditioning reduces infarct size. And if we perfuse with this MCBS compound throughout the whole procedure, that can bind to all that removed histones coming out of the cells and prevents some of the injury, reducing the infarct size significantly. So that was very encouraging. We also measured the amount of histone 4 again coming out of the heart. And you could see MCBS is reducing the amount of histones. So it's working as expected. It's binding to the histones, eliminating them. Interestingly, it looked like there was a reduction. It wasn't significant, but there was almost a similar extent of reduction with the ischemic preconditioning. Importantly, part of the discussion of the previous lecture, we heard to be clinically applicable, we need something which we can administer at reperfusion when the patient presents. We can't give it from the beginning of ischemia. So in these experiments, we added the MCBS to the perfusate just during the reperfusion phase. And again, you can see a very significant large reduction in the infarct size. So far, all of what I've shown you is ex vivo, far removed from the clinical situation, really, either on cells or isolated hearts. But to try and get into a slightly more physiological setting, we conduct studies in vivo as well. So this is the open chest rat model where we can see the heart, we can tie off the coronary artery, induce ischemia, and then reperfuse. And at the end, we see this infarcted region and some live tissue as well. So using this model, we see on average 60%. I should say each of these dots is an individual rat. So we averaged that out between these rats, and we see around 60% infarct size in the control rats. When we injected the MCBS, now you can see there's actually no effect. So this was a little disappointing. We'd seen in the ex vivo model, this MCBS could reduce infarct size. And that's why we need to use these more complex models. We can see, unfortunately, the MCBS wasn't working in vivo. So we were obviously disappointed. We thought about this a bit more. MCBS has been shown by others to be protective in certain models. This is from the Australian colleagues showing that MCBS would actually reduce death of rats in a septic model. But we were interested in ischemia reperfusion, and when we were doing these studies, there was an interesting paper published by a German group showing that this histone H4, which I'd mentioned a couple of times. This histone H4 they showed is actually one of the particularly toxic histone. And they conducted these scanning electron micrograph images of the surface of their cells. This is not in the heart in their study, but they show that these histones could go into the membrane and form large pores directly in the membrane, which really explains why it kills the cells. And that's their schematic for how that's working. But importantly, they also developed a molecule which could bind to the histone H4 specifically and prevent its activity. And they called this HIP-E, or as you can see here, HIP-E. And this complex protein, it's a circular protein, but it binds to the histone H4. They were interested in atherosclerosis in their experimental model and actually showed that it could prevent some of the, or improve the plaque structure. But we were interested in, as I mentioned, in seeing its effect in ischemia reperfusion. So they kindly provided some of this HIP-E compound for us to test in our experimental models. Firstly, in the cell-based model, this is what you saw before actually, but we're adding on here, treating with increasing amount of this HIP-E compound. Again, on the cells in a dish, we can prevent injury. And importantly, now going back to the in vivo model where the CBS compound didn't work, here we can see that the HIP-E does significantly reduce infarct size. And this was given just before reperfusion at the clinically relevant time period. So we do believe that the histones are toxic, but we need the appropriate drug to be able to do that and target histone H4 in particular. The final point I'll just come back to is I'd mentioned about the theory that histones act as a kind of a damp, and this has been discussed in the literature by other groups. We also did experiments of our own, and this was with colleagues in Norway who had a cellular model to look at whether basically the response of damps, which activate a transcription factor called NF-kappa B, and a sign of inflammation in the cells. And just to summarize, essentially what we found, there was no response by histone or MCBS in any of the cells in comparison to a bacterial extract where you can see there's a massive increase in inflammatory response. So actually in our hands, and we confirmed that also in a cellular model, the histones did not stimulate the toll-like receptor 4 pathway of inflammation. So they're not acting as damps in our model. This actually fits in with the German group, that the histone H4 is like drilling into the membranes of the cells and just destroying the cells. So just to summarize that in the end, I know this is very sort of basic experimental work at this stage, but what we're trying to elaborate is an understanding of the multiple different ways that ischemia reperfusion injury can kill cells. PI3 kinase is one way we can protect the cells, but perhaps by addition, we can also include agents targeting histone H4, prevent that toxicity of these toxic histones, and it might end up eventually, this is still at a very early preclinical stage, but we hope that eventually we can develop a sort of multi-target strategy to obtain maximal protection eventually in humans. So with that, I'll just thank our collaborators on the right. I mentioned the Norway group and Australian and German groups. And this was work was done at the Cardiovascular Institute by these individuals with a close contact, led also by Derek Yellen. And with that, I'll just thank you for your attention.
Great, thank you very much, Sean, for that excellent talk in this new area of cardioprotection research. Any questions from the audience? Klaus, please, at the front here.
Thank you, Sean. I'm also a fan of dams, as you will see at the end of it.
I was expecting a question.
Now, my question is, have you had the opportunity to sort out what type of histones? I mean, isolated ones or in association with the decondensed chromatin, the nets you find in your animal model, and whether,
that's a very important question, and something we've debated a lot really in trying to, I'm not really sure the best way of assaying and determining the structure of the histones. Maybe it's something we can discuss later. You might have some better ways to do that. We've simply used an ELISA to show that the histone H4 are present, but we don't know the structure of it, whether it's intact with the nucleosome or free. We're assuming it's free because that's largely the toxic form, but we haven't.
So you mean assay made from plasma or serum from these animals?
Yeah.
Okay.
Thanks.
Thank you.
Thanks, Sean. Explain why we or you believe that there's difference between the in vitro and the in vivo when it comes to MCBS, because I think that's important while we went on to the other drug.
Wow, that's a tricky question. You got me there because it's always difficult to know what are the differences between an ex vivo and in vivo model. MCBS it's not specific to histones. It's just a charged molecule, so it can bind to many different things.
So you think it's actually targeting lots of things and missing out the histone particularly?
Most likely. I mean, it's difficult to know because, as I mentioned, it was effective in sepsis, but that's a different experimental model. So potentially, in our model, it might be binding to beneficial signaling things as well as detrimental things. It's very non-specific. That's why we went for the histone H4 targeting, as you know.
Yeah, and of course, drugs. Heparin is a good example of a drug that will neutralize histones, and that I think people should be aware of that as well. Although it doesn't target protection in the same way, does it?
Yeah, I mean that's a perfect example of something which doesn't seem to be protective in vivo. So, although it's working by a similar mechanism.
Just for everyone's interest, Sean and I talk about this every day, trying to sort out the problem. And I'm bringing it to this bit. Sorry, Sean, but it's just something we've got to try and dig out and find out what's going on.
Sean, maybe I can ask a question here. So, I mean, the toxic effects of the histones, which cell type do you think it is in IRI? And could it be the immune cells? And of course, immune cells are not present in the isolated heart.
Yeah, as you say, I suspect it's probably not immune cells in the isolated heart, but it might well actually be the endothelial layer. We don't know, to be honest, whether it's something we need to look at, whether it's targeting the endothelial layer, which protects the part of the vessels and protects the myocardium, basically, or whether it's directly targeting the myocytes. Yeah.
I mean, it would suggest you need some sort of component in the blood, right, to get the protective effect.
What the protein?
You maybe a blood product, some other element of the blood.
Possibly, yeah, I don't know.
Okay, any other questions? Okay, Charles.
How do you know what the mechanism of killing is? Are there receptors for histones on the surface of cells?
I don't think it's receptor, it requires any specific receptor. It's really, this German group has done some very advanced imaging and modeling to show that it can interact with the membrane. So it's really the interaction with the membrane. And the histone H4 molecule has an extended domain which can probe into the membrane and then apparently cause these pores to form. I don't think any more is known about the precise mechanism, but that's essentially what's happening.
Thank you.
Whilst the audience are marshalling themselves to ask more questions, can I ask you one? As you know, I have an interest in many different forms of heart injury. So this appears to me to be potentially an area where many different mechanisms of injury, for instance, individuals undergoing chemotherapy for cancer, we would hypothesize because of the amount of DNA damage that there will be a lot of histone release. And as we know, some of those patients end up with cardiovascular issues, myocarditis due to viral septicemia, all these things. So do you think that this is an area of spreading the potential mechanisms of protecting the heart under different scenarios other than infarction?
Exactly, yeah. I think that's something we're interested in looking at or starting to look at as well. Cancer cardiotoxicity, you mentioned, is very important now to recognize, increasingly well recognized. And interestingly, in that case, we're deliberately targeting the cancer, killing the cancer. And no one really thinks too much about where all the products of that dead cell tissue from the cancer goes, histones are released and might be potentially contributing to actually damage to the heart.
I think the other advantage experimentally is that you know precisely when the damage is going to occur. You don't have to wait for the random event of an infarction. Yeah, question from the audience?
Okay, so thank you very much. Thank you.
Thank you, Professor, for such an informative talk.
Our next speaker is Professor Peter Ferdinandi. 4 times recognized as a highly cited researcher, Professor Ferdinandi has over 300 papers and 6 patents to his name. He founded the Pharma Hungary Group, a group of research and development companies that have been involved in more than 250 drug and medical device development projects since their foundation in the early 2000s. He was the president of the International Society for Heart Research, European section, and the chair of the Working Group of Cellular Biology of the Heart of the European Society for Cardiology. Currently, he is the Vice Rector for Science and Innovations and the Director of the Department of Pharmacology and Pharmacotherapy at Semmelweis University, Budapest. He is the President of the Hungarian Society of Experimental and Clinical Pharmacology and serves as the Editor-in-Chief of the British Journal of Pharmacology. I now invite Professor Ferdinandi to share with us his research on mRNAs in cardioprotection, development of protector MIRs.
Many thanks for the organizers for inviting me for this beautiful meeting, and especially beautiful Mauritius. It's really amazing nature what we have experienced yesterday. So I will talk about cardioprotection and the possible, drug development on the microRNAs. And actually, Derek Yellon already introduced the cardioprotection field. I will give you a little more introduction as well. And so here, probably what the audience here may know that in ischemic reperfusion injury, if you don't reperfuse, all the ischemic region would die. So currently what we need to do is either to shorten the time of ischemia and to do reperfusion and to protect the reperfusion injury. And what we know now is that it can be decreased by cardioprotective methods, and these can be drugs and also ischemic conditioning. But currently, the more recent results show that mechanical cardioprotection, ischemic cardioprotection, clinically is very difficult to use. And also, it seems that the hope was much, let's say, greater than the reality. So after 30 years, we still don't have any cardioprotective drugs. And it's also very important to say that ischemic reperfusion injury can be also aggravated in certain conditions, like cardiometabolic risk factors can do it, and also drugs can do it. And that's what we call cardiotoxicity, which is another very similar field of this ischemic reperfusion injury, because several drugs basically kill the ischemic cells, but they don't kill the normal healthy cells. So why don't we still have any cardioprotective drug on the market, although we know that for 35 years that somehow we can reduce infarct size, but more than close to 4 decades were not enough to develop any drug to the market. So, and the possibility, the probability for this lack of success, that the mechanisms of the injury is too complex, and also the mechanism of this mechanical cardioprotection is too complex, so it's very difficult to translate. So in fact, I haven't seen any second messenger or any cellular signaling where at least 5 papers wouldn't show that it somehow relates to cardioprotection. So whether this is really a kind of an exaggeration or not, we don't know, but in fact, almost everything is involved in this cardioprotective signaling. And so probably it's too complex. But we are focusing now on this non-coding RNAs, but I will show why, because later I will introduce that. So, and the other problem is that it's not only too complex, but there are too many confounding factors. So, including the types of the protection, types of the occlusion, the age of the animals, risk factors, and also the genetic predisposition of even the animals, even the healthy experimental animals have different genetic predisposition. So all this have to take into account. And moreover, not only the genetic predisposition, but when you do ischemic reperfusion injury and cardioprotective intervention, that also changes the epigenetic and the transcriptomic response of the heart. So it's really extremely complex phenomenon. So what can we do in this very complex phenomenon? We need to have new technologies. So we try to measure everything what is known and try to call the bioinformaticians and find out some ways to find some feasible targets. So one thing what seems to be valid now, that there is definitely no one dominant pathway for cardioprotection, but it most probably there are several multiple pathways which involves in cardioprotection. So for that, what we need to somehow to measure this functional genomic and proteomic program with which we could reduce myocardial ischemia, reperfusion injury, and the size of myocardial infarction. In fact, in many years ago, we started this omics approach to measure the transcriptomics, and we found out that there are hundreds of genes, the expression of which are changing in ischemic reperfusion injury and in cardioprotection, but at that time we couldn't really deal with so many data, back in the more than close to 15 years ago. And of course, another approach is the multi-target strategy. There's an excellent paper led by Sean Davidson. And this is another approach to try to find some multiple target drugs or to target multiple mechanisms. And the microRNAs are exactly a good choice for multi-target drugs to tackle some multi-target mechanisms, because this is how they look like. So this is a microRNA schematic drawing of the microRNA, which binds to an mRNA, and then it regulates the expression of this gene. So by this binding, this mRNA will be broken down, but at least the translation will be blocked. And so how can we use this technology for therapy? So we can use an anti-microRNA antagomer or antimer, which can block the original naturally occurring microRNA here, and therefore you can deliberate an inhibition. So this is the microRNA inhibition therapy. And the other approach is to use a mimic, microRNA mimic here, where basically you mimic the, naturally occurring microRNA or a similar molecule, an oligonucleotide, which binds to an mRNA. MicroRNA is roughly 20 to 22 nucleotide, oligonucleotide, actually. And it's very important to know that one microRNA has roughly 100 gene target with different affinity. And therefore, if you want to use different microRNAs, or if you see a differentially expressed microRNA, you definitely have to build up a molecular network, because if one microRNA targets 100 mRNA, and you have, for example, you find 10 microRNAs going up and down. So you need definitely a network mathematician to build up the network to find out some feasible mRNA targets. So, and these microRNA oligonucleotides, therefore, are promising therapeutics. So, because they are fine-tuned regulators of gene expression, they are multi-target drugs, and they do gene therapy, but in the regulatory perspective, these are still small molecules because these are just a short oligonucleotide, so you can easily synthesize them and repeat the synthesis. Currently, there are several oligonucleotides are already on the market, the so-called silencing or small interfering RNAs. We have 4 on the market now for different therapies, mostly rare diseases, but also for hypercholesterolemia. And also microRNA type oligonucleotides are currently more than 20 we found recently in the clinical trials.gov. And there are several indications where these oligonucleotides are being developed. So we started this oligonucleotide, therapy development many years ago, but then unfortunately we stopped it. But I show you, and now we restarted. I show you how we started. So 10 years ago, we just had a very simple experiment. So there's a non-ischemic myocardium, there is an ischemic reperfusion injury with an infarction, and we used preconditioning and post-conditioning. At the end, we measured everything, what we knew at that time. There was roughly 350 microRNAs known at that time. Now there are about 2,000 of them. And we were looking at certain expression types or expression patterns where, for example, the ischemic reperfusion injury upregulates a certain microRNA and either pre or post conditioning downregulates or vice versa, but at least it counter-regulates to ischemic reperfusion. And we found this microRNA, for example, heavily counter-regulated by preconditioning, this one by post-conditioning, and the most promising, of course, this microRNA, where those pre and post-conditioning showed a really huge counter-regulation. And of course, we patented these and published papers. We patented in 2011. And then we published a paper and basically stopped everything. But since the COVID came and RNA therapeutics became very popular, so we restarted and revisited all of our old patents. And this was just a validation of the, sorry, I forgot to tell. So we also validated these protectomeres. So we transfected cells with either the mimic or the antagomer, what was necessary. Due to the changes of this microRNA, and we validated that definitely 125B star is cytoprotective. So we revisited all these things now, and we further developed this microRNA 125B star. So we did a pharmacokinetic study with it, and actually it was quite druggable. So the half-life after an intravenous injection was quite okay. And also the target, the mRNA expression, we just selected 3 targets, and we definitely got a meaningful decrease of the targets after 8 hours after the introduction of these microRNAs. And the microRNA 25B star, we were able to decrease infarct size significantly. These were done in industry quality control system. So you see that for an infarct size study, you have to use at least 15 per group to have a real meaningful result. But definitely we managed to decrease the infarct size after 24 hours of reperfusion in mice. So, and then we also used from the drawer, we brought up some of the old samples of the pig study. So a large animal study is very important in cardiac drug development. So we had a huge large animal study with preconditioning, post-conditioning, and remote conditioning, and we had all these samples. So we sequenced all these samples for microRNAs, and the same what we were looking at, counter-regulation of either preconditioning, post-conditioning, and remote conditioning. And we found 4 microRNAs which were upregulated by all these conditionings, and 10 microRNAs which were downregulated. And we checked if these are patentable, and we validated, of course, some of them, and we found one microRNA to patent. Actually, this was a microRNA 450A. So we patented a couple of sequences around this microRNA just very recently, and we are further developing these molecules toward clinic. So what else you can do with this microRNA measurements? So, for example, if you measure microRNAs, you can also look at or discover new targets, new gene targets in any experiment. For example, this is where we used the rat protectomy, what we found 10 years ago. We built up a molecular network analysis with our own softwares, but we developed, actually you can use it for free for scientific purposes. And we also developed some mechanism to show the network to be understandable for a non-bioinformatician as well. This is this NTOP layout, what you can use as well as a plugin in your network software. And basically, we found out some actually very interesting targets for this protectomies, like Victor, which is an autophagy regulator. Actually. So with this network, you can find new genes involved in any disease, whether it's cardiac protection or any other disease. You can use this software. Another interesting thing I want to show you at the end, that with a group of Rainer Schultz from Giessen, we realized that there are, for post-conditioning, there are responder animals and there are non-responder animals. And when you just make 2 groups of the responders and non-responders, we measured the microRNA profile of these animals. And we also built a network of the microRNA and mRNAs. And what we found out that there are certain genes which are differentially expressed in the responder and the non-responder animals. And just these were just simple healthy rats. So these are the huge individual variation. The animals, it is still unpublished, but for example, what is very interesting that we found the cannabinoid receptor difference between the responders and non-responders. The others, like in this omics study, you end up with results but you have no clue what genes they are. You absolutely have no clue what the other genes are. We also constructed a mitochondrial subnetwork of this network. We already published this. And we also found some mitochondrial genes which were differentially expressed in the responders and non-responders. So this is what you can use with this molecular network analysis. So it's very useful to find out new genes. And that's my last slide. So what you can do with these softwares is that we did a systematic review and the network analysis of microRNAs in 2 ways. So first, we did a systematic review of the redox related microRNAs, which have been shown in the literature to be cardioprotective. And we ended up with so many different microRNAs in the literature. And on the other hand, we used a kind of a reverse prediction of our software. So we told our MIRNA target software that the target genes are redox genes. So all the redox genes were put in the software. And the software showed us which microRNAs are regulating these genes. And the cross sections were those microRNAs which were, we think, most probable for cardiac protection, because these are in the literature, they were experimentally validated, and with the software based on all the sequences we predicted as well, based on this network mathematics. So, and I think that's all. So as a take-home message, this microRNA omics, we think it's very useful for discovery of therapeutic microRNAs and also to discover new genes. And why is it good? Because we can measure microRNAs not only in the tissue, but also in blood and in any other bodily fluids. And also, for example, extracellular vesicle fractions are very rich in these microRNAs. So, and then you can analyze the expression pattern, and therefore you can discover protectomies or toxic microRNAs. And from here you can do two directions. So, for example, you could do this microRNA, mRNA target analysis, and then with that you can find out to discover new genes. And of course, you need to validate all these mathematical predictions in the wet lab, but you can end up with novel targets. And on the other hand, when you identify such microRNAs, these can be developed themselves as therapeutics, oligonucleotide type drug therapeutics, which we believe will be really in the future. So thank you very much for your attention.
Thank you very much, Peter, for that great talk. Any questions from the audience? Sean?
Hi, thanks, Peter, for an interesting talk. But, you showed that the microRNAs seem to take 4 to 8 hours to decrease the target molecule expression, right? So, wondering if you administer them at reperfusion, do they have enough time if you're adding in an exogenous protective microRNA? How do they reduce infarct size when they're taking that long to affect gene expression?
Yeah, so in fact, where we used in vivo studies, we used the 24 hours of reperfusion. We haven't measured the target expression before 8 hours, but taken into account that the human pathology of the infarction development extends to 12 to 16 hours. So even before up to 12 hours, I think that you can do reperfusion in the PCI unit. So I think within 16 hours, I don't know, I'm not a clinician, practicing clinician. So I think that the drugability of these oligonucleotides are there. And what was interesting that even with the 120 minutes of reperfusion, we were able to show some protection. So whether it's the effect on the genes or some other effects, we don't know, but we are still protected. So,
question from Klaus, and then Prof, and then
Thank you, Peter. You started out saying that in general, a particular microRNA has several targets as regards. Now, how do you want to specify or select particular targets for therapy?
We don't really care for the targets because we care for the it should be efficacy and safety. So where we show microRNA or a combination of microRNA is let's say reducing infarct size, then an advantage over other small molecules is that with this network analysis we can show which genes they mostly target. But if you develop a new small molecules, which is not a gene therapy, you have absolutely no idea what are the off-targets, because a small molecule can off-target everything, but you don't even measure. At least with these microRNAs, we know the off-target, so at least we can predict mathematically much better the off-targets than in any small molecule.
Okay, and then a short practical question. How much of a given microRNA you should apply, and how much of this injected or given microRNA will reach target cells. So what's the efficiency of targeting?
Yeah, this is a very interesting question. It's mostly it's a matter of the formulation. You know that these RNA types drug can enter into certain cells depending on the chemical modifications. It can enter into cells very efficiently or less efficiently. For example, with this 125B cell, even without any transfection reagent, we were able to show the expression in the myocardium, but with the commercially available Darm-effect reagent, the transfection reagent, the efficacy goes 100 times higher. So the dose is a very interesting question because you may know the PCSK9 inhibitor oligonucleotide. There is only one shot that is given to the patient, and the effect lasts for 6 months. So this is very interesting how long they actually stay in the silencing complex of the cells. So the dose is a very interesting question. We just out of the gut try certain doses, and yeah, we are happy if it's safe and effective.
Okay, question by Prof.
Thanks, Peter. Very, very interesting. I don't profess to know much about microRNA, but what fascinated me was that you saw upregulation and a downregulation, right? And to me, the downregulation is equally important to the upregulation. Have you taken those microRNAs that are downregulated and why they're downregulated, and have you added them to cells to see what effect it would have?
Yeah, so the idea, if I just go back. So the idea behind this is here was that, for example, if ischemia reperfusion severely downregulates something, okay, and pre and post conditioning counter regulates it, we thought that in this case we need to replace this microRNA. That was the simple idea, and therefore in this case we need a replacement of this microRNA. But for example, in this case, since ischemia reperfusion upregulated and post-conditioning downregulated, if we were to develop this microRNA further, here we need an antagomer so to antagonize this effect. That was the idea, nothing else. So, no magic. Yeah.
Just one more question. Any questions from the audience? If not, Peter, thank you very much. Can I just ask, you focused on perhaps therapeutics. I'm interested perhaps in diagnostics. Is the pattern of upregulation and downregulation a fingerprint unique? For instance, you do ischemic injury, might it be the same or different with a viral myocarditis or a potentially cytotoxic, cardiotoxic drug?
Yes, absolutely. So these microRNA fingerprints can be used as an in vitro diagnostic tool as well. The problem mostly with the patentability, it's very easy to bypass the patents with this because one microRNA, well, we give numbers to these microRNAs. Okay, so 125 base pair, but what does it mean? It means a sequence. But the microRNA has lots of sequences, what we still call 125 base pair. So this is a kind of a tricky. Our patent covers about 1 million sequences around 125 base pair.
Okay, thank you very much, Peter.
Thank you for your enlightening words, Professor. It seems that a member of the audience has misplaced one of their bags given at the start of this conference. If anybody finds a bag with the initials SE on the back, kindly place it here or give it to a representative. Thank you. Yeah, it's in a folder. It's the entire folder.
Our, our next distinguished speaker is Dr. Shamlal Umesh. Dr. Umesh is a consultant interventional cardiologist. He is the ex-president and present executive board member of Cardiovascular Society of Mauritius. He is also ex-executive board member of Medical Council of Mauritius, with currently being the head of the Department of Cardiology at Dr. A.G. Jitu Hospital, Port Louis, Mauritius. Now, I would like to invite Dr. Umesh to please come forward and give us an insight on his paper titled Implementation of 24/7 Primarily Percutaneous Coronary Intervention in Public Hospitals in Mauritius, how it impacted the lives of Mauritians.
Thank you. Good afternoon, everybody. It's always so difficult to be on this side of the floor when we have so many eyes focused on you and you have to deliver. This is where the first thing that happens is palpitation, which I'm getting right now. Our heart starts racing. And all of us who are present here, in one way or other, we try to save our heart as much as possible, be it in a case of MI, where we have to be very fast, where we have to act very fast, because time means muscle. And as the previous speakers before me, they very rightly presented, more time we take, more is the myocardial damage, more is the release of troponin, more is the release of histones. And if timely action is not taken, then we may end up in heart failure. Even then, we don't stop. Even in cases of heart failure, we cardiologists, we always try our best to get the maximum out of the failing heart so that we can live a normal life. We interventional cardiologists, I can see some of my colleague friends who are here as interventional cardiologists, we come from a different battalion. We don't work in labs doing researches, just like our senior colleagues, our professors do. But we need all of them to make it possible so that we can save our heart. So we come from a battalion where we act very fast. There is a war, our artery is blocked, our cardiomyocytes are dying. We should act very fast, go clean up things just like scavengers do, and try to establish the flow as fast as possible. So this is what interventional cardiologists do. I always put this picture first because this was my first primary PCI that I did in my life under the guidance of my mentor, Dr. Ashok Seth, and one professor who is here. So I'm going to present today the implementation of 24/7 primary PCI in public hospital, what was our initial experience, and what were the difficulties we faced, and where we are right now. So if we go by any guidelines, be it AHA guidelines, ACC guidelines, ESC guidelines, NICE guidelines, any guidelines or any local guidelines, they all say only one thing. That in cases of ST elevation MI, in cases of heart attack, in cases of STEMI, which looks something like this is a normal ECG. These are the coronaries, right coronary artery and the left coronary artery. When these are blocked, this is when we do a heart attack. So if we have an STS segment elevation like this, earlier the culprit vessel is opened, better is the immediate, short-term, and long-term outcomes. In MI, minute means muscle. It means cardiac muscle. So as time passes, we have got a part of the heart which is dying. So there are two ways to open the blocked coronary artery. One is thrombolysis. We use thrombolytics to break the clots, but that takes a lot of time. And the second one is PCI, where interventionally we go in the cath lab, we go in the operation theater, try to see which artery is blocked by angiography, and if need be, try to remove the clot mechanically. So thrombolysis was still used in most of our 5 regional hospitals till now. And coronary angiography for the patient who has done an MI, it may or may not be done before discharge, and the patient might be put on a list of coronary angiography waiting for his turn. Then a decision is taken whether to do a PTCA, to go for a coronary artery bypass grafting, or if things are very bad, to go in medical treatment. And if the patient happens to be lucky and he lands up in a hospital where cath lab is available and is free, he may benefit from primary PCI in some hospitals. So this is the NICE guidelines of 2020, which more or less says like reperfusion therapy has to be done as fast as possible. And fibrinolysis is offered if the patient is presenting in 12 hours of symptoms and PCI is not possible in the coming 120 minutes, in the coming 2 hours. But if it is possible, then primary plasty is the treatment of choice. So offer if presenting in 12 hours of symptoms and PCI can be delivered in the coming 2 hours, in the coming 120 minutes. And if PCI is done, then a drug-eluting stent is preferred. According to the NICE guidelines, upon the first medical contact of chest pain, an ECG and diagnosis should be made in the coming 10 minutes. And in a non-invasive capable center, in 10 minutes, we should thrombolyze the patient. And in PCI capable centers, angioplasty should be done within the coming 2 hours, and the artery should be open, that means wire crossing should be done in the 90 minutes to come. If a cath lab is available, primary PCI is a preferred treatment because the artery is open under vision, so the chances of failure is very less. There is lesser risk than with thrombolysis, especially with the risk of bleeding, because sometimes it may happen that the patient has come with an MI, but he dies because of bleeding, and that because we are using thrombolysis. So all these risks can be minimized by doing primary PCI. There is immediate relief of symptoms as soon as the artery is open, and the ST segment comes down as soon as the artery is open. So before 1st of September 2020, this was the date when I was appointed as head of department of one of our interventional centers. Our cath lab was open from 9 to 16 hours during the daytime. In the beginning, streptokinase, when we were doing the study that we did with Professor Yellen, then following which tenecteplase were used to, and now only tenecteplase is used to thrombolyze our patient. The patients were stabilized, treatment was deferred, angiography was deferred before discharge, or the patient was put on a waiting list and he will come when his turn comes. Then a decision was taken what to do with the patient. And the cath lab used to be closed after 4 p.m. on weekdays, after Saturday noons, Sunday and public holidays were closed. So all those patients who were coming to our hospitals with MI, we were mostly thrombolyzed. In cases of failed thrombolysis, a rescue PCI was needed, and these patients were transferred to our 2 interventional centers, one in the north and one in the south, which were operational. And that also depends whether there is a place, the doctor who is on call, and of course, sometimes it depends on the mood of the doctor. Oh, I'm tired today, I'm not going to come to the primary PCI, So some patients passed away on the way before reaching the hospital, and some patients even after doing angiography. Minute means muscle in STEMI, and precious time was lost in transporting the patient from one hospital to other hospital. And in the meantime, our cardiomyocytes were suffering or they were dying. This is a hospital where I work. This is G2 Hospital. And I was a bit fortunate to have a very young team. They were dedicated, they were young, they were dynamic, but the only problem was like we were not experienced as a team in primary PCI. Except myself, I did only one primary PCI in my life before coming here. But then somebody had to take that extra initiative, that extra mile to go. So I talked to my team and they were ready to take the challenge to start primary PCI on a 24/7 basis. We were 6 cardiologists, myself, 2 consultants, and 3 specialists. So since past 9 years, since our hospital was built, only streptokinase were used and tenecteplase were used afterwards to symbolize our patients. No primary PCI was done. On 1st September 2020, primary PCI at least was started as from during the daytime from 9 to 16 hours because our cath lab was still closed after 4. We had to get special permission from the ministry to open our cath lab. So on 21st/6/2021, the Ministry of Health, after n number of meetings and convincing them, they allowed us to give a pilot project at G2 Hospital for 24/7 primary PCI. And this was my first day. When I come, I find there is a patient who comes with chest pain, 38 years old, uncontrolled DM, smoker, 10 cigarettes a day. He was having some epigastric discomfort since last night. Then he started having central chest pain next morning at his site of work where he lost consciousness and he was brought to the hospital by his colleagues. We did an ECG and you can very well see what the ECG shows. Not a very good ECG. He has been suffering from previous night. So we can clearly see there are some ST elevations. And this was the challenge. This was the mile to go. This was the line to cross. Are we going to symbolize our patient or are we going to take him to lab? You have been asking for it. It's your first day as consultant in charge. You get one patient, 38 years old, go for it. So we went for a coronary angiography. And at the coronary angiography, this is what we saw. This is a right coronary artery, which looks more or less quite normal. And this is the left coronary artery. And in the left coronary artery, we can clearly see there is something, there is a haziness here. And there is one artery, those who are very familiar with it, that is missing. We passed a wire, and this is how we open an artery. This is what we interventional cardiologists do. Where is an artery which is blocked? Go for it, open it, try to save as much myocardium as possible and as fast as possible. So just after passing the wire, you see there is a flow which is in here. When we thrombolize a patient, we don't know how much time it is going to take for the artery to open. We just keep on watching the ECG. We keep on asking the patient, do you still have chest pain or not? We don't know whether it is opening or not. And in 30% of the cases, we are going to get failure. So 30% of failures thrombolytic. And in interventional cardiology, this is what I like about it. So as soon as the wire was passed, we can see there is a flow here. We put a stent here, and then this is what it looks like. We have another artery which is a bit sick here. We just leave it because there is a TV3 flow, and we get our artery back. This is what we expect our thrombolytic to do in the 2, 3, 4 hours to come, in the 12 hours to come. But the thing is, the more time it takes, the more myocardium is dead, the more heart failure, the more medications, more complications are going to come in with time. And this is what this man's ECG looks like. It doesn't look bad in the long axis. Here in the 4-chamber view, we can see there are some, this is 4-chamber view, hypokinesia of the apex here and here, but overall, it's a very good myocardium. It's a good contracting left ventricle. The patient was discharged on the 3rd day. Admitted today, primary PCI done. Tomorrow he goes in the ward. Next day he goes home. He was reviewed after 2 weeks, completely stable, no chest pain at all, and he is leading a normal life till now. So what are the advantages of primary PCI to the patient? The artery is open under vision, so chances of success are very high. The pain and ST elevation subsides as soon as the artery is open. A no thrombolytic is used, so risk of bleeding complication is down to almost zero. The EF of the patient is preserved, so his personal, professional, and family life are preserved, and he is productive in all aspects. Days of hospitalization in most cases is only 3 instead of 6 in a patient who is thrombolized, and number of medications are reduced, so the side effects to the patients are also reduced. There is early return to professional, personal, and family life as the damage to myocardium is very less. And what are the advantages to the hospital and the system? Days of hospitalization is half the normal course as compared to thrombolysis. So the bed turnover is simply doubled. 1 dose of tenecteplase, it costs around 50,000 rupees, 50,000 Mauritian rupees. And a stent, it costs only 7,000 rupees. Bearing in mind, if we thrombolize a patient, anyway, we have to take him to the lab to do an angiography to put a stent. So that adds up to 57,000 for one patient where we can do the same procedure in only 7,000 rupees. So up till now, till date, since 1st September 2020, in my center, we have done 340 cases of primary PCI. And up till now, we have saved around 17 million rupees in 3 years. Thrombolysis leads to bleeding complications. We have avoided all those bleeding complications like CVA, GIT bleed, which can sometimes be fatal or lead to serious handicaps. So all these can easily be avoided. Heart failure in case of failed thrombolysis, it adds up to the burden of cardiovascular disease and heart failure. So many medications, the expense is more, the side effects is more, and this is a vicious cycle which never ends. So our Ministry of Health, it purchases tenecteplase as follows. When we add up all these, it comes to around 2,500 vials a year for all the regional hospitals and the hospital in Rodrigues. And that amounts to, in an ideal situation where we do primary PCI in all the patients presenting with STEMI, to 125 million rupees that can be saved per year. One cath lab installation costs around 35 million rupees. 3 labs can be added to any hospital if we do primary PCI in all our 3 centers, possible on a 24/7 basis. And the money saved can be used for other developments in the health sector. There were, of course, some problems in the beginning, the problem of implementation, the problem of acceptance, preparation of the team and their approval. But fortunately, I was having a young team. They were very dynamic and they wanted to take the challenge under my guidance. Then we started having problems with the anesthetists and radiographers because they are always rare birds. Everybody needs an anesthetist. So it's hard to find them. Then the place to rest, payment issues, mess issues, but everything was settled finally after numerous meetings with the Ministry of Health and Wellness. And on 21st of June 2021, they gave us the permission to do 24/7 primary PCI. What was in fact our initial vision, it is that every patient presenting with STEMI should benefit from primary PCI on a 24/7 basis. Primary PCI, secondly, to be extended to all 3 existing centers and get 1 more center at GNH in the south and 1 in the eastern region at Clark Hospital. Every citizen of this country has a right to get the best treatment in case of STEMI, and that best treatment undoubtedly is primary PCI. What are the status actual state of affairs. After the tremendous success of initial pilot project at G2 Hospital, the Ministry of Health and Wellness decided to extend the project nationwide. Since June, July of 2020, the other two centers of the island have also started doing primary PCI on a 24/7-hour basis. Patients from almost each hospital, especially those where cath lab is absent, are being transferred as far as possible to PCI centers for primary PCI, depending on the availability of beds in the coronary care unit. A small spark that started at G2 Hospital has taken now a nationwide wildfire dimension. An introduction of primary PCI in our health system has brought a paradigm shift in the treatment of patients presenting with STEMI. And we can now say that we are at par with the latest mode of treatment as any developed country for STEMI patients. What best or what better can we give to a patient who has come with this than this? And I remember this patient in less than 15 minutes, his patient was shifted in the cath lab and the artery was opened. This is how a blocked artery looks like, and this is how an open artery looks like. If we wait for thrombolysis to do this, it might take hours, and in those hours, so much of myocardium is already damaged, and this took us only 15 minutes. So on 21st of October 2021, we received a special mention Giessen Award. CCU of G2 Hospital were the only public sector out of 80 who participated to win the competition of African Giessen Special Mention Award 2021 set up by the Japanese authorities. And on 6th of 10th, 2022, in Singapore, the Asian Pacific Society of Interventional Cardiology honored me with a fellowship and official board member of the society for the paradigm shift in the treatment of STEMI patients in Mauritius. And I dedicate all this to the whole team of Dr. G2 Hospital and all those involved in the success story. On 17th March of this year, we won the Public Service Excellence Gold Award set up by the Ministry of Health. And on 28th of July 2023, we won another award by the National Productivity and Quality Excellence Award. And the cherry on the cake was on 7th of April 2023, when the European Heart Journal, after the research and consultation with the President of Cardiovascular Society of Mauritius and other senior colleagues, published an article that read, "Small Country, Big Difference. How one physician's vision became a reality and transformed acute myocardial infarction management in the Republic of Mauritius." And I dedicate this to my senior cardiologist colleagues who told over the years on which I added a small piece of brick for primary PCI, and all those who were directly or indirectly related to the project to make it become a reality. And it is a moment of pride for all of us to have successfully achieved it. So in conclusion, primary PCI is the undeniable treatment of choice for STEMI cases worldwide, accredited by all renowned international guidelines since years. It is the best gift that can ever be provided to a patient presenting with STEMI. It has advantages not only for the patients, but to the health system and the society as a whole. There should be a political and professional will to impose such decisions in the benefit of all and to the system. We managed in less than a year to implement, change the whole cath lab staff, train them anew, and then now we are training doctors from other hospitals. Where there is a will, there always is a way, as we can find n number of reasons and excuses not to do it. A small additional effort is needed to go that extra mile to provide the best to our patients. Mauritius has the advantage of being a very small country, and any corner of it is reachable in less than 120 minutes, as recommended by all international guidelines. There should just be a will. After doing around 350 cases over 3 years, I can see our success rate is more than 99%. And primary PCI, though more risky, is easier to do than many other interventions and is the only procedure that saves lives in ischemic heart disease patients. Of course, we have a learning curve, and that learning curve, it comes with practice. And I thank you all for your kind attention. I'm here for questions.
Yep. We'll open, we have a few minutes for questions. We'll try and keep the time. At the front row here, Derek Yellen.
Umesh, thank you very much for that very clear talk, and congratulations on what you've achieved. It's remarkable. I'm going to just ask you a question, though. The way it's talking now, what you've achieved here, and you mentioned it's a small country and you can get people across. Does anybody need thrombolysis? Because we would argue there's still a case for thrombolysis. And I want to know how many of your patients are fortunate enough to receive primary PCI.
As I said, it all depends on the will of the doctor. There is a protocol that is imposed by the ministry. Now it's up to the head of department of those 3 cath labs that are existing, whether they do it or not.
But can those cath labs cope with the population?
Of course, yes. We have 1 cath lab in the center of the country where I work. We have 1 cath lab in the south. We have 1 cath lab in the north. So if each one of these cath labs cater for 1/3 of the population of the demarcated areas, and very soon we are getting one down south where Dr. Batuwa works, and we are going to get one in the eastern region. 5 cath labs covering the whole country of 1.2 million population. I think thrombolysis with time should die.
Thank you.
Question from the back up there.
Thank you, Umesh, for your presentation. Just some comments. If you don't know, this cath lab at GT Hospital was open. If you don't know, it was after the demise, the death of one of our minister, Mr. David. James David. So he was brought here, I think he was in Parliament, which is found in Portuguese. He was brought to Chito Hospital. I think, unfortunately, he died there. There were no cath lab. So since then, the government decided, in 2009, we set up a cath lab in Chito Hospital. Prior to that, there was only 2 cath labs at the Thomas Store, at Cardiac Center, and at Victoria Hospital in Condos. So since 2009 upwards, a cath lab was opened. There was Dr. Ramgoolam, who was there at CIC, and afterwards, Dr. Jagesa was there. So in view of the lack of human resources, so primary research was started, but only from 9 to 4. So we're waiting for more cardiologists to get trained in interventional cardiology so that we can go ahead. And thanks to Dr. Umesh and his team, they started at GT Hospital. And also I'm happy to say that at GNH, we're going to open a cath lab soon. The angiography is already waiting there in the corridor, just for working space to start the process. Thank you.
Thank you.
There was a question from the back. Please. This should be the last question, and we'll move on to the next.
It's always difficult to take a patient of acute MI in the cath lab. I can see my colleague friends, Dr. Doma is here, Dr. Suka is here. They have been our mentors in Mauritius for interventional cardiology. They have worked for years and years. And it's now the turn of our young generation of cardiologists who are sitting here to put that extra effort so that we can do primary PCI on maximum number of patients. Because this is what saves lives, and this is what is recommended by any international guidelines. Yes, sir.
Thank you, sir. Congratulations. You have a nice
coordinated centers. I want to ask, when there is a failed PCI, the patient goes to the surgeon. How it is coordinated, how long it takes for CABG.
It all depends upon the urgency of the case. For example, if a patient is having a left main disease, we have only one center that caters for the whole 1.3 million population of cardiac surgery. So if it is left main, for example, the patient is transferred almost immediately, but it all depends on the availability of beds. That is the main problem. The main problem is logistics. The main problem is not manpower, because at cardiac center, we have 5-6 cardiac surgeons who operate. So if there are no bed available, then that poses a problem. Sometimes patients die in coronary care unit. But those patients who are stable, who can go home, they go home and they are put on a waiting list for cardiac surgery. But those who need urgent intervention, they are taken by cardiac center. Thank you.
Thank you very much indeed.
Thank you.
Thank you, Dr. Ramesh. It was a very wonderful talk.
Our final speaker for this session is Dr. Dharmendra Sukar. Dr. Dharmendra Sukar is a consultant interventional cardiologist and cardiac CT angiography specialist. He graduated from Manchester Medical School in England in 1994 and obtained his MRCP in 1998. After subsequent training in cardiology in the UK, he trained for board certification in interventional cardiology at the University of Ottawa Heart Institute in Canada and in cardiac CT angiography in the USA, finishing in 2006. Since then, he is practicing in Mauritius in both the public and private hospitals and is the Vice President of the Cardiovascular Society of Mauritius. He has published the American Heart Journal and BMJ Emergency Medicine Journal. I now invite Dr. Sukar to speak on the complications encountered during cath lab in a hospital setup in Mauritius.
Thank you very much for the introduction. So my talk basically is going to be some case examples of complications in the cath lab in Mauritius and the rescue procedure performed by myself and the team in the cardiac center in the north. So first of all, just a brief mention of some points about complications. Important for senior interventionists to be covering junior doctors and also those who are in training or fellows who work with us. And sometimes we have patients having coronary angiography who may end up with complications during the diagnostic procedure or during the PCI procedure. And the importance of dealing with complications, especially with time, the type of cases we do have become more complex. We do more complex total occlusions, primary PCI, cardiogenic shock, also graft interventions, and these add to the risk of potential problems. So the importance of training and collaboration is very important. Discussing with colleagues, even over the phone, or calling the anesthetist, the cardiac surgeon, to help in difficult situations are important measures. Important also for even senior cardiologists to learn from cases and discuss with colleagues, and having a heart team in case of requirement for rescue is vital in the true sense of the word. You may have complications where sometimes you can be rare, can be catastrophic if not successfully managed. So in the hospital, recommendation of resources is important. In the cart, in the room, in the hospital. In the hospital, you need the cardiac surgeon for backup. You need the vascular specialist, echocardiographers, and experienced cardiac ICU. These are vital. You need the kits, for example, for pericardiocentesis, covered stent in case of perforation, and other devices which are useful. And in the room, you need all the drugs for advanced life support, defibrillation, and a number of mechanical support devices are also very useful. And if you do have a complication, it can be a minor complication, for example, a small perforation during ballooning, and these sometimes can be dealt with simple balloons or stents. Sometimes it is complex when you need what we call cover stent. These are double layers of metal with Teflon material in between the two, which can seal the perforation and save from catastrophic tamponade. If the patient is well and stable, you can assess the patient, can discuss the case with the heart team before proceeding with the complication. And general principles, first of all, you need to have regular drills with physicians and staff discussing what needs to be done in various situations. There are actually publications from Seattle recently with a government regarding various types of complications and how to deal with them. And these are actually important for both junior and senior interventions. Asking for help is a critical aspect of complication management, and this is vital. And also, you may have a colleague who may be not there, far away, but contactable by phone, who may actually help in difficult situations. Dissections can happen, and they can be minor, they can be major, they can be catastrophic, they can be fatal, and also experience in dealing with them is vital. And it's important to realize that sometimes some complications will be once a year, some of them could be once in a lifetime, and important to read also about complications across the world and how they're dealt with. And the procedure itself can be technically difficult. Sometimes it is doable, and if you have two colleagues working at the same time, a second operator can be very, very useful rather than having only one person dealing with a case. I'll show you this case. This was a diagnostic angiogram performed. I just wait for it to play. Okay. It is fine. Okay. So this is a patient having cardiogram. This is the left coronary artery. You can see the artery doesn't have much disease. And you just need to pay attention to what's happening near the left main. As the diagnostic procedure is nearly ending, the operator was one of my colleagues, and I was actually in the hospital. As you can see here, at the end of the procedure, there is distagnation. This is a circumflex artery, and the main artery in the front of the heart, the left atrial descending, has disappeared because of the dissection and acute occlusion. So I was called in an emergency basis in the cath lab to wire the artery very quickly and put a balloon to open the artery again. A patient was not well and the blood pressure crashed. We had to give inotropes to stabilize the patient, put two wires, one in the LED and one in the circumflex. This is a stent in the left ventricle descending into the left main, so stent to the left main. Unfortunately, there's a problem that happened, and I'll show you. The circumflex artery, after opening the LED onto the left main, had clot formation. You can see clot. So this is actually a complication within a complication where the LED and the left main has been stented. So here we're ballooning the circumflex artery and then putting a stent through the stent of the left main onto the circumflex to rescue the big circumflex artery. And using balloon to optimize the expansion of the stent in the left main. So this patient actually was then sent to the ICU and was stabilized, and echocardiogram showed the LV function was normal, ejection fraction 60%, and the patient did okay. And the reason why the patient did well, one was we intervened very quickly. The whole thing was done within 10 minutes, and the anesthetists were there to support the patient. The cardiac surgeon also came in case of inability to do this, to take to theater, but unfortunately we didn't have to do that. The next case, sorry, I think it's probably the same one. I think it's probably the same case. The second case was a patient who was referred from G2 hospital. Patient was having a coronary angiogram, and the left system was found to be okay, but there was a problem on the right coronary artery. As you can see here, there's a tight narrowing, but during the procedure, something happened, which led to referral to us. You can see there is a spiral dissection in the right coronary artery during the procedure due to the catheter, and then there's no reflow distally in the right coronary artery. So this is an acute myocardial infarction that has happened during the procedure of the diagnostic angiogram. And the patient was unstable, had tachycardia. You can see a temporary wire was put in. And the patient, because they did not have balloon pump, unfortunately, on that day in G2 hospital, the patient was sent to the surgeon, query whether surgery is required or could be done. And the surgeon showed us the case, first of all, to see if we could try angioplasty, first of all. So you can see this spiral dissection within the coronary artery. We'll try to wait for it to play. The patient came to the cardiac center in the north and was still in pain. Blood pressure was going down and patient was stabilized with inotropes. And as you can see here, wired the artery and then stented the distal part, first of all, to seal the track of the dissection, and then proximally to seal the beginning of the dissection. And the part in between was also stented with two other drug-eluting stents. We are optimizing the size of the artery here, proximally, and then a stent in between the two stents. And we managed to treat the myocardial infarction, though 4 stents was required. And the artery was patent. We actually lost one of the side branches here, but because the patient was unstable, we did not want to venture more than that. And the patient was actually much better the next day and transferred back to G2 hospital. Briefly talk about perforation. I've already mentioned that, so we won't go into detail. I don't have a case of perforation to show you, but no reflow is another problem that we see sometimes. And as you can see in this case, the distal vessel was blocked with clot and all that. And with ballooning and medication, the artery was opened successfully. In case of pulmonary collapse, we have intra-aortic balloon pump. Now we also have ECMO in our hospital. And Though the cases for ECMO were surgical, they were not for PCI, it is actually one of the things that we have available now for rescuing cases. This is another case which is a bit different. The patient has lymphoma and had a portocath inserted. Unfortunately, the portocath inserted migrated into the subclavian vein, and the patient was referred to us to try to see whether we can fish the portocath in order to avoid surgical or vascular intervention. So basically, the access was from the femoral vein, and we use a catheter and a angioplasty wire. We loop it around the catheter inside the vasculature, and then tighten the loop so that you actually get hold of the embolized device, and then pull it out from the femoral vein. We've had a few patients like that. There was another one where the catheter was embedded in the artery. Probably was there for a while, and then with the existing devices, we couldn't manage to retrieve it with special devices that we have. But with the homemade devices, like just a simple catheter and looping the wire inside the catheter and trying to catch it, was successful. So you can see here, sometime while pulling it down, you may lose the contact, or you may lose the control, but you can easily actually loop it back again and then pull it down into the femoral vein. The femoral vein is a structure that is accessible to the vascular surgeon, and they can actually get it out for us without much trauma to the patient. I'd just like to show you one last case. This is a case of diagnostic angiography, which was done by one of our fellows in our hospital. And then, unfortunately, during the procedure, there was dissection at the ostium of the right coronary artery. And if you pay attention to the aorta, you will see some staining that starts to appear. Unfortunately, the operator did not realize that and kept on doing more injections. And you can see this is coming up, that there is a problem at the level of the aorta with the dissection happening. So dissection into the aorta is a problem. It's a bit like the dissection of the artery itself, but if it retrogrades, it propagates backwards, that can be dangerous, and also it can be potentially fatal if it is severe. Here, we call the surgeon, and the surgeon asks us to try to see if we can seal the ostium, the beginning of the dissection. So, though normally we do not advise injecting when you have a dissection, here to get the stent in the right position, we had to take more pictures. So you will see that the stent inserted here to try to seal. There was a dissection in the middle of the RCA as well, and trying to seal the beginning of the dissection. This is dye in the wall of the aorta, and as you can see, the picture is progressing. Patient was bradycardic, needed temporal wire. So we tried to rescue the coronary artery in this difficult situation, and tried to minimize injection after rescuing the artery. And this is the status of the aorta. One of the worries the surgeon had is there something surgical that needs to be done. So we did a CT scan, which didn't show any problem within the wall of the artery. The size of the aorta was within normal limits, and the patient was well. The ECG also had normalized. You had acceleration again in this case. And the patient stayed on ICU for 2 days and was eventually discharged after about day 5. This is my last case. We obviously have quite a few of the cases that we potentially could show you, but that would be for some other time. The take-home message is, first of all, it's always important when there are problems to call the seniors, because the seniors sometimes can help. It's true that some cases can be fatal, whoever is doing the surgery, but in order to involve the surgeon, the anesthetist, and the interventionist, along with the person who was doing the case in the first place.
Thank you very much.
Thank you very much. I knew there was a very good reason I hung up all my balloons about 5 years ago, and you just remind me of the good reasons why I gave up doing it. Okay, are there any questions or comments from the floor? I mean, what I would say is what you're doing now to this audience is important, but what you do in sharing these things to the audience of the trainees is even more important. Recognition, and as you rightly say, the simple steps of calling for help, of seeking advice, and if you have the support, as you say, of anaesthetists and surgeons. For at least half of my career, I worked within interventional centres without surgical cover, and that really is difficult and can be problematic, and you learn to face it and deal with it. But I'm very interested. Thank you very much. Any questions or comments? Well, I think everybody has become rather hungry. And it just takes us to thank yourself and thank all the other speakers and the speakers from the floor for this session, which has been very illuminating. Thank you very much.
Thank you very much. Thank you. Thank you for your insight, Doctor.
Before we move forward with the session, little information regarding the water condition. So for all those who want to keep themselves hydrated, we have drinking water just outside the hall, so you can just go and have some water.
I now request Professor Walker to come on stage and present the certificates to our esteemed speakers. I request Professor Sean Davidson to receive his certificate. I request Professor Peter Ferdinandi to receive his certificate. Thank you, Professor. Kindly be seated.
I now request Professor Hossenloy to please come on the stage and distribute the certificates to our distinguished speakers. I request Dr. Shamlal Omesh to please come on the stage and accept the certificate. Now I request Dr. Justus-Liebig-University to please come on the stage and accept the certificate. Thank you, sir, for distributing the certificate.
I now invite Professor Claus to present these certificates to the chairs. I request Professor Malcolm Walker to receive the certificate.
I once again request.
Thank you, sir.
Now I request Professor Derek Hossenloy to please come and accept the certificate. So with this, we have come to the end of this session. It was an intriguing one. Professor Davidson, Professor Ferdinandi, Dr. Omesh, Dr. Sukur gave us an insightful talk on public health, myocardial infarction, and cardioprotection. And with this, we hope our audience takes with them these ideas forward and maybe present them with new answers in the future. Thank you, everyone.
We shall now proceed to lunch. The moderators are requested to make themselves available in the D Hall in 15 minutes for poster viewing. All attendees are informed that the feedback form for the event is accessible via the QR code displayed. All are requested to scan and give their valuable feedback. Thank you.